Welcome to another edition of the Inspired Stories podcast, where leaders share their experiences so we can learn from their successes and be inspired by how they've overcome adversity. My name is Anthony Codaspoti, and today's guest is Dr. Greg Sawchyn, Regional President at WellBe Senior Medical. Now, WellBe specializes in caring for older adults facing complex or chronic conditions. Their mission is to help patients lead healthier, more meaningful lives through compassionate personal care while promoting physical, social, and emotional well-being. Greg joined WellBe in December 2022 and has a strong background in value-based care. He previously served as Vice President of Value-Based Care at Sound Physicians and Senior Director of Product Strategy and Innovations at Ohio Health. Greg is also a physician with an MBA in corporate finance from The Ohio State University, which gives him a unique perspective on both clinical and business strategy. Through his work, he has helped design programs that improve patient outcomes while reducing unnecessary costs. Today, we'll learn how Greg's leadership and medical expertise guide his team at WellBe to deliver top-notch care to seniors in Ohio. Now, before we get into all that good stuff, today's episode is brought to you by my company, Add Back Benefits Agency, where we offer very specific and unique employee benefits that are both great for your team and fiscally optimized for your bottom line. One recent client was able to add over $900 per employee per year in extra cash flow by implementing one of our innovative programs. Results vary for each company, and some organizations may not be eligible. To find out if your company qualifies, contact us today at addbackbenefitsagency.com. All right, back to our guest today, the Regional Market President of WellBe Senior Medical, Greg Sawchyn. I appreciate you making the time to share your story today.
Yeah, thanks, Anthony, for inviting me.
Okay, so Greg, before you started your professional career, you obtained a lot of formal education. You have an undergrad degree, an MD, medical degree, and an MBA, all from The Ohio State University, and all back to back to back. Sometimes people will get a degree, go work for a while, figure out that they need some additional schooling, but you got it done all in one fell full swoop. Did you have kind of a vision of where you wanted to go in your life right from the start?
Yeah, I mean, I think that from my history, I don't necessarily recommend it for everybody. I mean, it's one thing where things kind of progressed and fell into place, and I just kind of went with the momentum. To be honest with you, even throughout undergrad, and it doesn't really show necessarily just by the end result, but I kind of went between science and business the entire time. Actually, sorry, the stream said it paused, but I guess not. I actually switched my major like 4 or 5 times in undergraduate between science and business, and I still managed to get out in 4 years. So that was definitely an accomplishment. And then stayed at Ohio State at the time. He's the current chief medical officer over at Ohio State. Dr. Thomas had started this like combined MD and MBA program. So you could actually go in and do a combined degree between getting a medical doctorate and an MBA, and decided to join on with that and pursue it until the end. And, there were a couple other folks in my class. I actually keep really good touch with all of them. And so, it just ended up working out that I wanted to be in this space between the science, the medicine, and the business side throughout. And I've kind of charted that path through my career in a kind of back and forth kind of way.
And so, yeah, you mentioned that in undergrad, you kind of went back and forth. So you had an interest in both areas from an early age. Where did that come from? Did you grow up in a household of doctors or business people?
No, I'm actually the first person in my immediate family to go to any college. My mom is a registered nurse, retired. But back then you didn't really have to go to college to be a nurse. You kind of went from like a high school to just go get an RN in nurses training. And my dad just really had a high school education. So I kind of grew up a little bit around nursing, but really it was kind of high school where I just really enjoyed science and learning more about it. And But at the same time, I enjoyed numbers, and business and numbers seemed to go together for me. And, I've just kind of tried to push those two things together throughout my career.
So let's maybe talk about some of the stops along the way. I'm looking at your LinkedIn page here. Right out of school, it looks like Lancaster Pollard. You were an associate and then a VP there. What did you learn here?
Yeah, so Lancaster Pollard, middle market investment bank, focused on hospitals and senior living. I actually had the opportunity during my MBA to meet somebody who was already working there. And, really he told me about the firm. So he was going to get his MBA, planned to go back to the firm, and it just seemed like a good fit. Got to know them a little bit over the course of probably about a year. And then ultimately decided to join the firm right after I finished my MD and MBA. Had the opportunity to really start learning about how the healthcare system works from the business side. So you go to med school, it's all science, it's all physiology and how to take care of patients, which is great. I mean, that's what it should be. But your typical MD gets out and they really don't know anything about the sort of business of medicine, maybe to the detriment. And I think that if you talk to most doctors, they would say that they wish they had more of that training during their medical career. And then similar with MBA, like it's a very sort of generalized business kind of education, not a lot about healthcare specifically, but just generalized business things. So by going to Lancaster Pollard, it really gave me the opportunity to kind of get some of the drivers of healthcare business. What I really focused on there was critical access hospitals. So there's a program that exists in the federal government where a hospital can get what's called a critical access designation. So if you have 25 beds or less, you can be a critical access hospital. And there's some special reimbursement rules with Medicare, the way that works. This critical access hospital designation really came into popularity kind of when I was kind of starting with that in the mid 2000s, where a lot of Hill-Burton hospitals. So Hill-Burton was an act of Congress back in, I think, like 1950s that allowed a lot of these rural areas to build hospitals. But they'd always struggled, to retain medical staff, to be profitable. And so a lot of these facilities were in somewhat disrepair. And then some, more favorable reimbursement came online in mid 2000, and that gave them the opportunity to replace their facilities, renovate them, and things like that. And so we did a lot of business doing that, and I got to learn a lot about hospitals, especially in kind of rural areas, and the drivers. And it was really great learning experience for me.
What does this critical access hospital designation allow? What's the advantage of having this?
Yeah, so typically under Medicare, you get like a DRG reimbursement for an inpatient admission. So basically, like Medicare will say, hey, this patient's in your hospital for heart failure, and then we're going to make some adjustments to it, but we're going to give you $6,000 for that admission. Doesn't really matter what your costs are, what the inputs are, or anything like that. It's just sort of a flat payment. What critical access did was kind of take the reimbursement system back to the way it was before the DRG system came into place, where there was like a cost plus reimbursement. So basically they got 101% of their costs. And there was, very formulaic how you actually came up with cost, but that included like interest and depreciation on a building, a hospital building. And so because of that allowed them to go out and actually issue bonds and borrow money to replace or renovate their hospitals. Interestingly, that besides critical access, the other sort of DRG exemption that exists out there are like National Cancer Institute facilities. So, on complete other end of the spectrum from like a 25 bed. And, I even worked with hospitals that had like 7 beds. To like the James Cancer Institute, where they have a similar sort of reimbursement structure that allows them to build very large and nice buildings.
And is this how has this critical access hospital designation actually played out? Is it proved helpful? Is it helping these hospitals in sort of these smaller towns stay afloat?
Yeah, I mean, it's tough right now for small hospitals in rural areas. So, and I think this has helped. It hasn't solved all the problems. I mean, there's a number of issues. One, in order to operate a hospital, you have to have a medical staff. You have to have physicians that are willing to be there. The reality is it's harder to attract physicians to want to practice in rural areas. You actually, as a physician, can make a lot more money going in a rural area than you can even in an urban area. It's somewhat sort of backwards of what you would expect, but that's one aspect. And the second one is just by having a smaller facility, you still have to have resources and things like that. So it is more expensive to operate. And so, it has been very tough and continues to be so for rural hospitals. And then you see a couple strategies. One, they're trying to just hang on. You have seen a lot of facilities close, or they affiliate with a big health system, like in Ohio Health or Ascension, or somebody like that can give them an umbrella to help allow them to continue to operate in a rural area. But it's I wouldn't say that it's been solved by any stretch of the imagination.
Mm. So in 2009, you moved on and you founded your own company. What was that?
Yeah. So, in 2009, I ended up sort of breaking off from Lancaster Pollard and started my own financial advising company and started taking on sort of finance consulting sort of gigs as well as operational consulting gigs, really catalyzed by a necessary move in my personal life. So my wife's also a physician, and she got a fellowship, a very great fellowship in ophthalmology in Philadelphia. And so we ended up having to go out there, and which, kind of took me away from all these critical access hospitals in Michigan that I was working with. But, it ended up being something that was a huge risk. I mean, I ended up, walking away from a job, a steady paycheck, and now you're on your own where, if you're not bringing clients and things like that in the door, you just don't get paid. Like there's no such thing as vacation time. There's no such thing as sick time. There's none of that. It's just, whatever in medicine terms, you use this term, you eat what you kill.
And when you talk about bringing the hospital in, bringing them in for what purpose? The service of?
So to consult with them on similar sort of financing arrangements. So like I would work with either hospitals on, like a renovation or, something like that they want to do for their facility, but actually ended up kind of migrating more towards working directly with physicians and physician groups on joint ventures with health systems and medical office buildings and things like that. And ended up being a really nice niche that with the MD and working with other physicians, you sort of like, you get what makes them tick, but you kind of bring this like a little bit more business experience to them, so that as they're doing these negotiations with health systems and things like that, then they've got somebody in their corner who can really operate at the same level as the specialized people at the health system when they're talking about joint ventures and things like that.
What do you think the future of these small rural hospitals is? My mother-in-law is affected by this up in Northeast Ohio. They've had their hospital close and bankruptcy looming and acquired. Is it going to be acquired? Is it going to be shut down? And it seems like it's kind of a common story right now.
It is. Unfortunately, that's the case. I mean, I think when you look at the spectrum of healthcare, what used to exist in rural areas as well as urban areas is like you build a hospital. And then that hospital provides all services to all people, and that from OBGYN services to complex surgeries and things like that. The reality is that's just not going to be practical. I mean, a rural hospital with 25 beds isn't going to be able to hire and retain a cardiovascular surgeon for just that facility. It's just there aren't enough cardiovascular surgeons around, and there probably honestly wouldn't be enough volume at that hospital to really justify the expense. And so what I think you're going to see over time, and I think you already are seeing quite a bit of it, is clearly you need hospitals, you need facilities in rural areas, or people can't live there. I mean, you need healthcare. It's not going to be all telemedicine. It's just not practical. You need to be able to lay hands on people to be able to take care of them, especially in an emergency. So I think what you're going to see is, these like emergency rooms with, call them emergency room plus, where I can treat you in an emergency. I can do some observation. I can do some procedures. I can stabilize you. But if you need something big, then I got to transfer you to a bigger facility. And similarly, like even in cities, like you have these sort of mid-tier hospitals with like 100, 150 beds. You can make a strong argument that like those facilities shouldn't really exist either. Like if you really want to get efficient, There should be a couple very large facilities that have, everything 24/7, hundreds of ORs, that kind of thing to really take care of complex conditions, because it's one of those things where, there are economies to scale. And as you see in medicine, the technology, which is amazing, isn't cheap. I think that even in Columbus, Ohio here, a bunch of the health systems kind of got together to buy one of these like protein beam therapy things for cancer, because they just realized that like, hey, we're not all going to buy one of these on our own. So we just need really one for the city. So that's what they built.
So what is that protein beam therapy unit?
All right, you're getting out of my area of expertise, but it's a radiation sort of treatment modality that has like a very focused beam to go after like a tumor in cancer. So like normally like radiation, you radiate everything. It's my understanding is like the protein beams functions more like a laser, where it's like a very direct hit of a certain type of radiation to a tumor. But you need to, they're very expensive. I want to say like they spent $50 million on this thing. Somebody could probably correct me on that. Like are
there specific types of cancer that it can be used on?
Yeah. Yeah. You really have to ask an oncologist for the details of that.
We've really gone outside your realm. Okay. Let's bring it back.
I think probably most solid tumors and, things like that, you would probably, be this, but whether that or traditional radiation, you'd have to ask an oncologist for sure. You don't want my opinion. And this is something else. I appreciate
you staying in your lane.
Yeah, exactly. Yeah. Like trust the experts. And I'm not an oncologist.
All right. So let's go back to the business that you started back in 2009. Looks like you ran through 2017. What was something you did there that you're most proud of?
There was a physician group that was in a joint venture they'd already done this joint venture with a large health system. And that health system, for its own sort of financial, difficulties, was really trying to strong arm them into, selling this asset. It was a medical office building to a REIT, a real estate investment trust. And this was like back in like 2009. And so it was, the middle of the great financial crisis. So, everything was going for fire sale prices. And this health system was just trying to unload this asset for its own cash reasons and everything else. And they were trying to bully this physician group into kind of going along with it. The physician group brought me in and said, hey, I'm not sure this is a good deal that they're trying to do. And I kind of, helped them and went through the financials and everything else. And it was not a good deal. It was a terrible deal. Basically, they were going to be selling it for just a little bit more than the debt they owed on it. They would have walked away with their investments, but not much else. And so we kind of put some strategies in place basically to assert their control over this joint venture and, just kind of delay things. And sure enough, the market kind of settled itself out and things started coming back. And we actually did end up selling it. I think it was 2 years later. And they all realized actually like a 10x return on their original investment. Wow. Because, that's the way leverage works, right? So you have like a bunch of debt on something and then the equity is based on sort of the gap to that debt. And so the asset itself was probably valued at, call it 150% of what this health system was going to sell it for. But because of that, their equity went up something like 10x. That's what they got to go home with. So, I was just happy because I was proud of it because, you have physicians that, again, they don't get a lot of business training. They don't get a lot of that. And then, somebody was really trying to take advantage of them financially. And, it was kind of why I decided to do that during that part of my life, was to kind of be in their corner and kind of give them an equal seat at the table of, how they could really operate.
Oh, it had to feel very rewarding. So you had this company till 2017, about almost 8 years. Then you decide to kind of wrap that up and move on. What was behind that decision?
Yeah, so it's interesting. So I started at Ohio Health, and Ohio Health was effectively like a client of mine. They were kind of getting into value-based care. got to know Dr. Bruce Vanderhoff, the chief medical officer there at the time. He's over at the Ohio Department of Health now. And just, really had a good relationship with him. And he kind of told me about kind of what they were looking to do and whether I could be helpful with that. And so I said, yeah, like, let's do this. And then actually took them on, and they were, a large client. I was spending half my time there. And eventually they said, hey, we want to do more of this. Do you want to come on full time? And I said, yeah, I think so. I'm at a time in my life where that makes a lot of sense for me to do. And I love the work that I was doing in this value-based care space. So made that move and decided to kind of let the other sort of consulting stuff run off and join Ohio Health full-time at that point.
Yeah, there's security, especially as you're starting a young family. There's security and, kind of having a regular stable paycheck from a well-established employer like that. And so you started out in director, clinical guidance councils. You moved up supply chain medical director, senior director, product strategy and innovation. Kind of tell me about this ascension.
Yeah, so it really paralleled what Ohio Health was doing in the space at the time. Was I'd say when I started there, very early in sort of this value-based care journey. And really as a hospital system, they were going through what a lot of health systems were going through at the time, is that, you essentially had this, call it confederation of hospitals. You had a bunch of hospitals that had always just kind of operated independently, but were part of a system because there's some leverage there and reasons to do that. And under the leadership at the time, they said, hey, we really want to become a system. Like, we want all the pieces to actually work together. We want the system to be before the sort of confederacy of hospitals. So moving from a confederacy to a federal system in more ways than one. And so, as they did that, they started these things called clinical guidance councils to bring in the specialty areas from the different hospitals and kind of agree on standards of care and practice and best practices amongst all the hospitals, so that where you would go is at the end of the day, if I went to one hospital or another hospital or another hospital and you had the same condition, you'd be treated in the same way. That wasn't necessarily true prior to that work. And then as, so
this is really about standardizing the care across all the different locations?
Yeah, in an evidence-based way. So you kind of looking at what's the literature say that we should be doing, and looking at sort of the best practices from a lot of really smart experts in the room in whatever the specialty was. It was one of those learning experiences where, you definitely trust the experts in the room. Like when you get a bunch of really smart, critical care doctors around a table, you're going to get a good result at the end if you just listen to them. And that was sort of our approach there, to look at the different specialties of medicine and really come up with those best practices.
You've used the term value-based care a couple of times. I can kind of infer what it means by, the words in the phrase, but the fact that you keep packaging them together, I have a feeling it kind of has a bigger meaning here.
Yeah, I mean, there's a lot of definitions out there, and people will say value-based care is this or that. At the end of the day, it's doing what's most efficient to get you the best result, which, for any business or practice or specialty or trade, I mean, that's ultimately what you're trying to do. How do I employ resources in an efficient way to get the best result at the end? And it's taken different flavors throughout that, but it's really a shift in thinking from the way medicine has traditionally operated. Like traditionally, it's like you show up in the ED and it doesn't matter what's wrong with you. I'm going to pay you the same amount and you're going to get the same sort of thing. Value-based care says, okay, well, let's look at, do you have something that's serious? Do you have something that's not serious? And we're going to treat those and pay for those and apply resources to those in different ways, depending on, what we expect the ultimate outcome to be.
So your time there at Ohio Health, what was the thing that you were most proud of?
We came up with a way to be innovative, and the giant 30,000 employee organization always has some difficulties with innovation. I mean, but it operates as a bureaucracy almost by necessity, and the momentum and the flywheel kind of do their thing, and kind of changing that is very, very difficult. One of the things we actually did was come up with a fund to effectively internally seed, like in like a venture capital kind of model, innovative things coming from clinicians that were evidence-based, that might have a major impact on efficiency or better care and things like that just didn't make sense necessarily in sort of this fee-for-service world. So I want something that's, FDA approved and, evidence-based and everything else, but the insurance companies don't pay enough for it to cover the cost of the intervention. But it's still the right thing to do for patients. And
we're talking about like, I don't know, different pieces of hardware or different medications or?
There was some of that. Yeah. Hardware, medications. We actually, one of the things was like an analytical tool that we could build into the EMR to like kind of push out evidence-based medicine of, what's appropriate to order an MRI on and what's not, and that kind of thing. But yeah, exactly that of kind of looking at some of these things that, don't necessarily get directly reimbursed, cost more than what we're currently doing, but might result in a better outcome at the end. And then we measured all of that as we did these sort of fundings and looked at the end and said like, hey, this worked, this didn't work. This is one of the things that made a lot of sense. One of the to give you an example, one of the things that we did that I really enjoyed doing it because it was novel, and it was one of those things that like this makes a lot of sense. Was like a special nutritional shake for people going into complex oncology surgeries. All right, so like I'm going to give you a bunch of these like milkshakes. There was no dairy in them, but I'm going to call them milkshakes anyways. I'm going to give you a bunch of these milkshakes, and I want you to take like, I don't remember, it's like 2 a day for a week before your surgery. Because there was some evidence out there that these things made a difference in post-surgical complications, faster recovery, things like that.
What's in these shakes? Just vitamins or?
Yeah, it was, they're kind of like an Ensure shake, but they had some extra stuff in them. They was called like immunonutrition.
Pixie dust.
Yeah, exactly. I think they were like made by Nestle, and it was it wasn't a bunch of chocolate, or it wasn't like Nesquik or anything. But
so it wasn't a product that you guys developed, but you wanted to include this in the course of the.
Yeah, we did not develop it, but it was something that was on the market, but not very widely used. Partly because like there was no reimbursement for it. So like you're a hospital system, and I'm going to go do a surgery, and my surgery costs this amount, and I can do that surgery and get my reimbursement by just doing these things. Why would I go out there and spend an extra $100 for a bunch of milkshakes for the week before surgery if I'm going to get paid exactly the same amount, whether I give you the milkshakes or not? And so, this was one of those things that like, there's no way they had no reason to approve that in sort of like this fee for service, like maximize profit kind of environment. And so we used it, and like I said, they didn't cost much. I mean, it was like $100 for a course, and these people are going in for $10,000, $20,000 surgeries. It wasn't a overwhelming amount, but the thought is that you have faster recovery, less complications. And it was a small sample size. I don't remember. Dr. David Arisi is the one who kind of pushed this along. I don't remember if he published anything on it or not, but anecdotally, and in the data that we saw, the complication rate for the patients that had the milkshakes was actually a little bit lower than the folks that didn't have the milkshakes. Now there could be lots of confounders and things like that in there, but it was something that was like, like there's something here. And it was just really interesting to kind of look at the scenario and see how it played out.
Did that program get continued?
We continued them for a little while. I actually have no idea if they're still doing them or not. Okay. Yeah.
So, I mean, that's a fascinating idea, and I love it. Like I love innovation, and I love that it's sort of like, hey, this isn't something that we're going to get reimbursed for, but this could produce a better outcome for the patient, which in the end is better for everybody, right? They don't have to come back. That saves money. It's less money out of everybody's pocket. It's less time. It's better health result for the consumer. Before we move on and talk about kind of your next couple of stops, is there one more of these innovation projects that might be interesting to hear about?
So let me tell you about one that actually like did not give us the result that we wanted. because, like that one I thought
we learn from those things too.
Yeah. So one of the things that we did, there was a software suite that we could, I alluded to it earlier, embed in the electronic medical record, the system, Epic system, that would, produce alerts for like evidence-based practices. And, it was one of those things where there was an analytic on the back end. So we kind of knew things that were evidence-based, things that were not evidence-based, and kind of how all that worked and who was doing certain things. And, ultimately, it ended up not working out. We ended up not actually turning on the alerts. There was a lot of concern both amongst the physician and the administration that it wasn't firing. It might lead people astray. Now, at the end of the day, the physician could say like, okay, well, thanks for the reminder, or I'm just going to ignore it and do whatever I want. But ultimately, we ended up not turning on those alerts for a variety of reasons. Like an example of one of those alerts, like vitamin D testing. People do this all the time today, and it's sort of the bane of my existence. I live in Columbus, Ohio. Columbus, Ohio in February is very cloudy. You can make a bet that virtually everybody in Columbus, Ohio in February is vitamin D deficient if you were to do a test on them, unless they just had a trip to Florida or something. So, I can do one of two things. I can say, hey, take a vitamin D supplement or take a multivitamin or, something like that, a couple times a week. And that'll make sure your vitamin D is where you need it to be. Or I can go get a, $50 to $100 test that tells me what I already know. And then my treatment's going to be the same anyways. I'm going to tell you to take a vitamin D supplement. Maybe I'll give you a shot of vitamin D, which, it might raise it a little bit faster, but doesn't really have a huge other effect. And there are conditions where you do want to do vitamin D testing. But like for the average person going into a primary care office, there's no evidence basis that, everybody who comes in should get a vitamin D test. And there's plenty of primary care docs out there that are doing vitamin D testing on all their patients, even though you already know the result. I'm in Columbus, Ohio, like you're in February, or March, you're vitamin D deficient. Just take a supplement. They cost, a penny
You
a day.
avoid the cost of the test and you just take the supplement, which is relatively inexpensive and unlikely to cause you any harm if you didn't actually need it in the first place. Am I right?
Yeah. So, ultimately, again, you don't win them all. And that continues to be anytime I hear vitamin D testing, I'm just like, what are you doing? What's the indication? Why are you doing it? Because, in 95% of cases, the vitamin D testing that's being done in this country is completely unnecessary.
An unnecessary expense. Okay. I really want to get to WellBe, but you had one more stop before that. Tell us about that.
So after Ohio Health, I went to Sound Physicians. Sound Physicians, national hospital medicine, mostly organization, but also emergency medicine, critical care, anesthesia. At the time, biggest participant in the Medicare BPCIA program, the Medicare Bundle Payment for Care Improvement Advanced, I think for the acronym.
Wow.
For that. So basically taking what I alluded to earlier, hospitals are reimbursed on a DRG basis for a hospital admission. Well, now I'm going to give you essentially a payment for not only the hospital admission, but for the 90 days thereafter. And so if you have a complication, if you have a readmission, if you go to a skilled nursing facility or an inpatient rehab, that's all sort of coming out of it. And so, the ideal scenario is you're going to the hospital, we're going to fix you up, and then you're going to go home and you're going to get better and you don't come back to the hospital. You should be rewarded more than somebody who goes to the hospital, then, goes to a skilled nursing facility, then goes home for a week and then, decompensates, gets readmitted to the hospital, goes back to a skilled nursing facility, gets readmitted. You can do this several times over 90 days and many patients do, but the hospital systems never really had any incentive to change that because they got paid every time that patient comes back to the hospital. The skilled nursing facility gets paid for every day that patient's in the skilled nursing facility. And so everybody's just sitting there like, hey, well, I don't really care that much about the complications because I get paid every time something bad happens. Well, under this program, you kind of got paid more for having a good outcome, which, aligns with really the way things should work. I guess you could call it kind of like a warranty. And because of that, we did this hundreds of hospitals across the country, and really had the opportunity to learn a lot about the way different health systems work. So before I went very deep at a place like Ohio Health, and now I'm working more superficially, probably with virtually every like big name hospital system in the country in some way, shape, or form because of Sound's overall reach. I think at the time we were in 400 or plus hospitals across the country. And so really learned a lot about, people will say health system, like when you see one health system, you've seen one health system. I completely disagree with that notion. The health systems that exist in this country all operate on almost exactly the same way. They all have the same motivations. They all have the same goals. Many of them have sort of developed in exactly the same way. They've taken a strong hospital or maybe two hospitals they had in a city, and then they start adding hospitals and they grow. And they're all essentially doing the same things, maybe at different paces, and maybe the political power within that system is a little bit different. Maybe the financial health is a little bit different just based on where they're operating. But, all the big health systems in this country actually all operate almost identically, no matter what sort of the headlines tell you about that not being the case.
So, Greg, this is a fascinating model that you're describing here, and it makes a ton of sense, right? It aligns everybody's goals. I'm curious, how did the data actually play out?
So it really depends. And effectively the federal government, it might still be going, but they rug pulled it for lack of a better way of putting it. Because, there were certain aspects of it that didn't necessarily align with the way that they intended to. So like in certain scenarios, like if I'm going in if I'm a relatively healthy person, I go in for a total joint replacement. It's a great program, right? So I go in for a total joint replacement. I'm in the hospital for a day. Actually, most total joint replacements are being done outpatient now. But let's say, I have to be in the hospital for a couple of days. And then I'm going to go home. And then I just had my total joint because I had arthritis or something like that. The idea is I'm going to get better. You shouldn't have done the total joint if the person's not going to get better. But then if you have complications, if you have to do all that, then you end up, not doing as well as if you do a total joint and the patient goes home. For us, Medicare actually changed some of the rules where, because we were a hospital medicine group, we were disadvantaged in that kind of scenario. So like, if you think about the way a hospital works, if I'm an orthopedic surgeon, I'm going to have somebody who comes into the hospital for a day or 2 days to have a total joint, no complications. I'm going to keep them on an orthopedic surgeon service in the hospital. They'll probably never be seen by a hospital medicine physician because the orthopedic surgeon's just going to come in around and say like, hey, wound looks good. How you doing? All right, time to go home. However, if you have complications, if there was some sort of trauma or something like that was involved, and that's why you had to have the total joint, basically you're a more complicated patient. You might be there for a longer time, but you're also going to see a hospital medicine physician. Inherently, the risk of that patient is higher. And because of where Sound was positioned in this, it made it very difficult because like for the instance of a total joint, Medicare sort of changed the rules and said, hey, it doesn't matter what kind of physician you are, you're going to get paid the same amount. Your target price for this episode, this 90-day episode is going to be the same. And so we essentially had to figure out how to take very complicated patients that will naturally have a more complicated course, higher likelihood of readmission, higher likelihood of going to skilled nursing facility, not because of anything we're doing, but because of the risk associated with that patient, evidenced by the fact that they were even seeing a hospital medicine physician in the hospital. It just made it impossible for us to do well. And so we ended up kind of pulling out of the program basically completely because of that.
And the government shut it down.
Yeah, I think it might even still be out there in some form, but basically all the big participants that were doing it, the amount of participants decreased like 90%.
Okay.
And so,
yeah, I guess on the surface, it sounded like, why haven't we been doing this all along, right? Everybody's goals are aligned. Let's keep, let's do our best job to keep, folks from those complications and from the readmissions. But, right, there's the wrinkle that you just threw in there. It's like you've got some patients that are just naturally more complicated. They've got more, comorbidity factors that are at play here. And so How do you factor that all into the calculation? It becomes
Yeah. And so this is, so, like that's sort of the clinical aspect of it. There's certainly a financial. So let me put on my business hat for a second. There was definitely an arbitrage opportunity that existed in target prices because of this. It was a very complicated methodology that CMS put in place. You could make an argument way too complicated. And one of the things I've observed about healthcare, the more complicated a system is, the more easy it is to game. And you could shift things around and you could increase your target price, deliver exactly the same amount of care, but do really well. And so, there was a lot of that going on as well. So that's essentially, the federal government will say that's why they rug pulled it. I don't think they'd use that term, but, I see why they did it. But at the same time, there was a lot of good stuff going on too. But like most things, it's, I think it probably could have been tweaked more versus just saying like, hey, we're going to shut this off altogether because some players in the space were definitely gaming it.
Yeah. Okay. So December 2022, you joined WellBe. This is what I really want to talk about. What you're doing now. What drew you to WellBe? What did they got going on that was so exciting for you?
Yeah, it was interesting. So as I mentioned, Sound was exiting this BPCIA program. So, you kind of see the writing on the wall, right? I'm brought in to kind of help manage this giant program across the country. And we're going to decrease our participation by 90%. It's like, well, you got to find my days here are probably numbered. So, and so I started kind of putting feelers out there and that kind of thing. And one of the folks that reached out to me was a independent recruiter named Steve Klopfer. And he's like, hey, let me tell you about this company called WellBe Senior Medical. And honestly, I'd never heard of them. They were operating in Ohio at the time. I'd never heard of them. And he tells me about this company, and I'm just like, you guys, I really like this, where you are with this. So WellBe overall, we're taking care of the highest risk seniors in their homes. And so, as I mentioned, value-based care, applying resources to the people who need it the most and not necessarily applying resources to people that don't need it. The way that WellBe works is that we'll take sort of a patient population, and it's all under Medicare Advantage for a variety of reasons. But basically, we'll go to an Aetna and say hey, give us your top 20% of sick patients, and we'll take care of them. We'll take full risk on them, and we're going to send somebody out to their home to take care of them. And so by targeting this top 20% of patients, in what is admittedly an expensive care model. I mean, it's not cheap to put a physician or a nurse practitioner into somebody's house to take care of them because, you go into a primary care office and they're seeing 30 plus patients a day. And they're just, hey, I've got 10 minutes to spend.
So how does this meet the definition of value-based care?
For WellBe?
Yeah.
Yeah. So, primary care, 30 patients a day. I've got 5-10 minutes to spend with you. There's a subset of those patients, called the top 20% of sick people, that need a lot more than 10 minutes at a time with their primary care physician. I mean, these are folks that, one, have a lot of different medical conditions. So they've got the heart failure on top of the COPD, on top of this, on top of that. They also have potentially a lot of sort of social issues, like social determinants of health issues, food insecurity, housing insecurity, families that may or may not be supportive. And, a lot of kind of complications there. Potentially you have low health literacy. The patient and their family don't really understand what's going on with them, because they get it 10 minutes at a time in a primary care office where the person's, typing on the EMR half the time. So
it's not necessarily less expensive. It's just more appropriate level of care.
Yeah, that's
in a setting that's more comfortable for the patient.
Yeah. But ultimately it ends up being less expensive. So while our physician services and our nurse practitioners, they cost money and everything else, it pales in comparison to the cost of an ED visit or a hospital admission or unnecessary care that patient's going to get. And so even though our sort of physician services cost more, and they don't cost anything, the patients don't pay anything for it. It's all sort of covered. We're at full risk. So we're actually, we sort of eat our own costs as part of the model.
What do you mean you eat your own costs? So, you're being reimbursed by Medicare?
No, we don't. Well, because of the billing rules, like we get a fee for service reimbursement for doing essentially like a primary care visit when we go into the home. But that's not how, like we would be underwater. We would never make money if we did that. Effectively, what we're doing is we're taking full risk on these patients. So what that means is that, like an Aetna gets $20,000 from Medicare to take care of a patient. Today, before WellBe gets involved, let's say that patient costs $25,000 a year. So Aetna's underwater $5,000 on these patients. And again, these are just all relative terms. And they're losing money on these patients. Now, Aetna makes a lot of money on the healthier people. But, for these patients, they're losing money because they're not being, well managed, because they're trying to be taken care of by 10 different specialists, each seeing this patient for 5 or 10 minutes at a time, getting different stories. And, it's kind of all over the place. And so the patient's not getting any better. They're back in and out of the hospital. We'll come in and we'll say, hey, okay, we will take risk on that patient. So, all right, Aetna, you give us the $20,000 that Medicare is giving you. And if the patient costs $25,000, then that's on us. We'll make up that difference. But if we can get it done for $18,000, then, WellBe makes some money. Now, our model, might cost, and again, I'm giving you just relative, $1,000 to take care of that patient. So we've gone from, we're getting $20,000 from CMS, $18,000 in care costs. Our costs are our internal costs are like $1,000. So now we're at $19,000. Medicare gives us $20,000. There's like a $1,000 profit there, versus where Aetna was before, where they're like getting the same $20,000 from CMS, uncoordinated care, more hospital admissions, more ED visits, and they're coming out $25,000. So they're losing $5,000. So it's like a win-win. Patients in the hospital less, patient ideally is getting better. The insurance company isn't losing money. It's just more efficient, kind of better care.
What's the single biggest factor in this being better care? Is it the fact that you've got one physician who is spending more time in being the quarterback?
So the way that we operate, it's a concept we call a community. So we'll have a physician and like nurse practitioners or physician's assistants. And, some of this varies by state, depending on what the laws and regs are. A community will take care of, call it 2,000 patients. And those 2,000 patients belong to this community. And that's a physician, a bunch of nurse practitioners, pharmacy, social work, behavioral health. It's a care team. An individual nurse practitioner will only take care of, call it 200 patients at a time on their panel. So they're responsible for the care of 200 people versus, 10 times that if you're a primary care physician.
Is that right? Wow.
Yeah. So imagine like you're only responsible for 200 people. I mean, you probably know 200 people, you know a lot about them. Like, and so like your job is just to like know these 200 people, know their families, know what's their conditions are. That patient has the WellBe phone number that they can get a hold of a provider 24/7. Not necessarily their provider, because we don't make our people like be on call 24/7, 365. But when you call in during business hours, you're going to get your own nurse practitioner on the phone, like, hey, John, how you doing? I know you were in the hospital last week. Everything okay? You need me to come see you today? Because we don't stack our nurse practitioners with 30 patients a day with no time slots, no time to spend with people. And so if, patient John needs somebody to come out just to hang out for an hour and kind of get their meds right from the hospital stay they just came home from, we can go and spend that time with them. And by getting their meds right and them not doubling up on meds and things like that, which happens very frequently when patients get discharged from the hospital, it prevents another ED visit. It prevents a readmission. It prevents John from, taking too many medications and getting dizzy and falling down and needing a surgery and things like that.
So you may have just answered my follow-up question, which is, could this same model of having a community of medical professionals caring for a smaller collection of people work where you're not going into the homes, where they're still coming to visit you physically in a doctor's office?
Yeah, I mean, that's essentially, and there's other entities out there doing that, like ChenMed, all clinic-based, very similar model, where you have small panels, people coming into the office. Oak Street Health, same model, clinic-based, complicated patients come into the office. Our difference from them is that we're actually kind of targeting the same patients, but we're all home-based. So we'll come out to the home versus having the patients come into an office.
Which one of those models do you think is more financially efficient?
Our model for sure. So, you talk to ChenMed or Oak Street. I mean, those clinics that they build are not cheap. And they're building a clinic. It's just a normal clinic.
So even though your medical professionals have got all this travel time, going to see folks, that the fact that you don't have this expensive medical facility wipes out the difference of those inefficiencies.
Yeah, it really does. And so because of that, I think that we are more efficient than those other entities. And, there's also a complicating factor here. So in order for patients to go to a clinic-based thing, remember, we're talking about the sickest patients, lots of social issues, potentially lots of, comorbid conditions. They can't always get to a clinic. You're talking about folks that maybe they drive, maybe they don't, maybe they have a family that can drive them, maybe not. We deal with a lot of homebound patients. We have a great success story of a patient down in the Cincinnati area that hadn't been out of her house for a significant amount of time. I think it might have been measured in years. Except, they would have a child that would take them to some of their doctor's appointments every once in a while. Until we got in the home, we didn't know, nobody knew that this patient couldn't get out of the house otherwise because they were wheelchair bound and they didn't have a ramp. And so one of our social workers called up an organization down in Cincinnati and that happens to build people ramps. And so they literally went in a weekend, took them, half a day. They built this ramp and the patient was able to get out of her house for the first time without assistance in years. And it's just one of those things, one from being able to go and kind of recognize that situation and do something about it. That patient's life was materially improved by that taking place. And nobody that patient was seeing in a clinic had any clue that was the situation. And so you have these patients not only in that situation, but also that just can't get out at all. If you can't get a ride from your daughter to your doctor's appointment, you're going to miss the appointment. You're going to have to reschedule it. Well, that might have been an important appointment, and now you're in the ED 2 days later because you missed an infusion, you missed some medications. By us going into the home, you have the ability to take that complicating factor of getting the patient from home to the clinic out of the equation. And I think that is something that is underappreciated as a huge risk factor of patients not showing up. You talk to any physician in the country and ask them, how often do all your patients actually show up for their visits? And, there's the reason why a lot of physicians get overloaded is because all the patients actually show up. It actually kind of operates like an airplane model where they'll sell more tickets than they actually have seats because they know some people just aren't going to show up. Yeah. But if everybody shows up, then they got to figure something out and just work extra.
So what does the data show, Greg, in terms of improved efficiencies, better patient outcomes with your model versus the traditional?
Yeah. So, our model, we do have a demonstratable month over month decrease in overall patient costs. Now, you can make an argument hey, everybody's costs are going to decrease because you're taking the most expensive people. When we have a population, we call them engaged and unengaged people. So not everybody agrees to our services right away. We'll call them up and we'll say, hey, we're from WellBe. We work with your insurance and, we'd love to come and see you. Who are you guys? I don't know who you are. No, you can't come and see me. Anybody, if somebody calls you up and asks you something, if you get them to pick up the phone, which, I never pick up the phone if I don't recognize the number, you probably don't either. And our patients are the same way. You don't get seen. But we do have a lot of data on them because we're already at risk for them. So we'll actually look at people that never see us and we'll look at people that see us. And we consistently see the cost going down of the patients that see us, whereas the patients that don't see us see their level or they're kind of moving up a little bit. And so we have very good data that shows our model works. We also have other objective data on quality. So HEDIS, which is a Medicare Advantage stars rating. So there's different rules in Medicare Advantage that there's certain advantages if you deliver high quality care. And quality, they have 20 something measures from breast cancer, colon cancer screening to if somebody prescribes you a statin, are you actually taking it? And they measure all this stuff objectively. The number of stars ratings that our patients have are generally 4.5-ish stars out of 5. And our patients typically come in, because these are, again, very complicated patients, like 2.5 stars for that population. And so we're materially, like even the way CMS measures it, increasing the quality of care that's delivered to these folks.
Is the data that we're sort of talking about in a general sense, is it considered proprietary, private information, or like, would you be able to send us links to somewhere on your website that we could put in the show notes that, people could kind of look at this?
I'm sure some of it's proprietary, some of it's out there. Like I know that on LinkedIn, we've all been kind of posting this thing about our stars rating, because we're very proud of that. It's a challenge for all Medicare Advantage plans to deliver sort of high quality and get to 5 stars. And the patients that we take care of, like I said, they come in 2.5 stars, are really the patients dragging down an entire Medicare Advantage population for a payer. And then by us taking some of the toughest patients and getting them to that, kind of highest echelon, it really bumps up the entire plan. So we've kind of put a lot of that data out there. And I'll try to find you a link and send it to you.
Yeah, if you can. I think that would be neat for everybody to check out. I certainly know that I'd love to see it. So what is your role then, Greg, as the regional president?
Yeah, my role is to kind of coordinate all the resources in a market, as well as, coordinate things with health plans, and, do a lot to just make sure the market is running well, and making sure that we're meeting our metrics and that we're not spending too much money, and, that kind of thing. So, I kind of take care of our Ohio market, which is our biggest market. We've got like 40,000 attributed patients here, but I'm also covering New York, Oregon, and Utah as well. So that's
a little bit of travel.
It is, yeah, it is, but it's very it's very doable. I'm kind of used to it at this point. As I mentioned, from previous consulting to Ohio Health, one of the things that I did there was, there was a lot less travel involved by going to Ohio Health. Now my kids are old enough. We were talking, just a little bit ago. I got a 14-year-old, 11-year-old, and almost 9-year-old, and they're old enough now that I can do a little bit more travel. And honestly, I don't mind going to Park City, Utah at all.
That's not too rough. Yeah,
our office is in Salt Lake, but
you'll divert while you're out there. Yeah. You gotta put in a little R&R time too.
Yeah.
So is there a big focus on growth at the moment?
Yeah. So we've been growing kind of like crazy. I mean, and it's been a wild ride. I mean, so I've been here a little, going on 2.5 years now. When I joined, there were less than 200 employees at WellBe. We're currently at right around 1,000 employees. So you've grown 5x in just from number of employees in 2 years. And I think our overall attributed population of patients has grown maybe even a little bit faster than that. And so, it's been a wild growth ride for sure at WellBe.
What do you attribute that growth to?
I think we're in the right place at the right time. I mean, I think, this home-based care is something that I think people are starting to recognize, for the same reason that I just described with, some of the deficiencies of a clinic-based model for this patient population is one thing. 2, Medicare Advantage plans are very focused on their stars ratings. And as that data kind of gets out, we're getting a lot of phone calls of Medicare Advantage plans that are looking for that help. And so, I think generally you have a space right now where everybody's trying to figure out what's the best way to take care of these like really sick people, this top 20% of a patient population. And I think there's just universal recognition in the medical community that you can't just force these people into a 30 patient a day primary care model and expect to get a good result at the end. You need to be able to spend more time with these people, ideally in their own setting, like home, and hold their hand. I mean, like, some of what we do is, we provide medical care. I mean, we've got physicians and nurse practitioners, but I'll tell you, like, the secret sauce is really listening, and giving the patient and their family the time to ask questions, to understand what's going on, to be able to work with them, to hold their hand. I mean, like, that more than the medical care we provide, which, all these patients have 10 specialists that are providing great care, but like nobody's ever tied it all together to them. Nobody's ever asked the patient like, hey, how do you want this to go? Like what is your interest? Do you understand what's going on with you? Do you understand where this goes? And what do we want this to look like? And just, being able to spend an hour or 2 hours with the patient and their families, which in many cases nobody's ever done, despite all these complications, that's really what makes the big difference in the care that we're providing. I think people are recognizing that.
You guys are looking at the physical, the social, and the emotional well-being.
Yeah. And honestly, I think like the emotional part, like you have objective data and everybody likes numbers, but when you go on one of these visits with one of our nurse practitioners, it's just being there for the patient, listening to them, listening to their family, and helping them out where they need help, and that's something that is not really capable of being done when you're seeing 30 patients a day.
Greg, do you think that this model could work for patients that are outside of the sort of 20% most ill, or do you think it specifically works just for that population because of all the things we've talked about?
It would have to be different. So, our goal is to make in-home care accessible to everybody in America. So the model that we're delivering to this top 20% of patients, like it would not make sense for a provider organization to deliver me that level of care. Like, honestly, like unfortunately, I'm in pretty good health. I go to my primary care doc once a year. They do a little blood work that may or may not be evidence-based, but I have to do it because of health insurance and biometric screening and the whole deal. And that's all I really want. Like, honestly, I don't want somebody in my house once every couple months, for an hour talking to me about my health. I'm like, I'm fine. I like, how about we skip the visit and I'm just going to go for a run and we'll just call it a day. So, like the exact model that we're delivering would not work for everybody. There's a flavor of it that would. I mean, honestly, my experience could be improved potentially by going all telemedicine, with, delivery of services to me. Like, if you need blood work, it'd be really convenient if somebody just came to my house to take my blood. Now, whether you can make that work from a business sense or whatnot, I don't know, but we got plenty of growth ahead of us with this top 20% population. And honestly, those people need it more than me. So, I think that's going to be our runway for the foreseeable future. But ultimately, our goal is to be able to provide in-home care for everybody in America.
Greg, let's shift gears. I'd be curious to hear about a serious challenge that you've worked through in your life. What was it? How'd you get through it? What did you learn?
Yeah, I mean, I think like even going back to the my consulting days is a good example. I during that period took on another big client that was taking up half my time. Venture backed, working with Israeli medical device companies, and it was a really novel approach to how to bring single device kind of companies with really novel things to the United States. And ultimately, it didn't work out. The company ran out of money. And so, from that point, having to go through as, an executive on this team to not only telling everybody working there that, hey, like we're closing up shop, but then also like effectively firing yourself. That was tough. I mean, like I said, I was spending half my time with that company at the time. It was a good chunk of change that I'm like, yep. Greg, you look in the mirror and it's like, you're fired too. And there's nothing you can do about it. It was the situation it was, but I think what I really learned was that, nothing in the professional world is really, it's not existential. It's not like somebody just gave me a terrible diagnosis that's going to alter the rest of my life. It's something where like, you learn to appreciate like what's really important and what's not. And you sort of, and in the moment it's tough. I mean, like you're like, what am I going to do? And it seems like really bad. And
I got bills to pay, got my family to take care of. Yep.
Exactly. So, but at the end of the day, it's like, you work it out and you're fine. And sort of, I think that experience has guided me quite a bit in other things. It's like, like I gave you the example of the sound position. The Fed's changed the rules. I kind of see the writing on the wall. I'm like, well, you almost approach it with a seriousness, but you got to have a little bit of a sense of humor about it. Like, yeah, seen this story before. Let's see where this goes. And I think that it's one, maybe more optimistic in a professional sense that, yeah, things will land. I don't know exactly where they'll land. I don't know when exactly they'll land, but they'll land. But I think it's also maybe just appreciate more in my personal life, the sort of the blessings that you have. I mean, like I've been fortunate that, nobody has given me a terrible diagnosis, knock on wood, that's not going to happen anytime soon. But, it's one of those things you appreciate every day more, I think. And you really try to focus on what's truly important and what can be changed, what can be mitigated, what can be figured out versus what can't be figured out.
It almost sounds like your experience as a physician has kind of helped to inform this perspective, because you said, I mean, losing a job, I mean, that's a huge stress. In your case, losing a client, that was a huge part of your income stream. That's a huge stress. But the fact that, you could sit there and say, at least I'm healthy. I don't have a bad diagnosis. And as a physician, somebody who's worked in the medical field, I have seen that story over and over again. Something that would be well out of my control. Something is, to use your word, existential. And so, yeah, I kind of get that sense that your experience as a physician, is kind of set you up to have that, I think very healthy perspective on big life events like that.
Yeah, I think so. Now, don't get me wrong. Like the first time it happened, it feels existential. Like I can't imagine anybody who loses a job, loses a big client, has some sort of major sort of professional setback, doesn't in the moment, especially the first time it happens, feel that it's existential. And I guess the sort of advice that I would give them is like there is another side. Like you as long as you allow yourself to get through it, you will get through it. And I see people that similarly potentially have that and really struggle to recover from it. Not just from like, hey, I need to find another job or things like that, but that it permanently scars them. And probably holds them back even further in the future. And I guess sort of like my advice is like, just lean into it. I mean, like you survived it. If it happens again and again and again, like you'll be okay. And actually the more repetition you have, the more likely it is that you'll even end up with like an even better result.
It's interesting what you said, lean into it. Almost like sort of being afraid of the fear itself is causing it to be worse and to stick around longer.
Yeah, I think that's accurate. And I go on LinkedIn and things like that, and you see folks that are, I generally feel empathy for them. Saying like, hey, I've been out of work, I've got 800 applications out, and 2 people have given me interviews, and it's like, I wonder how much those folks potentially are holding themselves back because they're almost sort of either projecting that fear or projecting sort of a sense of doom or something as they're kind of going through this. It's like you have to elevate yourself above the situation and like really focus on yourself and like what personal blessings and what personal is really going well, and put things in perspective that if you're well enough to be posting on LinkedIn, like you're probably in pretty good health. Enjoy it, get outside, go for a run, so it's kind of my sort of attitude about it.
Greg, I've just got one more question for you, but before I ask it, I want to do 2 things. First of all, for everyone listening today, this has been a fantastic episode. Dr. Greg shared a lot of interesting insights into the industry with us. Who do you know that might be interested in listening to this as well? Go ahead and take a moment and hit that share button, send it along to them. Dr. Greg, I also want to let people know the best way to connect with you. What would that be?
Honestly, it's probably something like LinkedIn. Fortunately, I have a very unique last name. You're not going to find another Greg Sawchyn. There is one more Greg Sawchyn. He lives in Canada, and I once met his boss on a beach in, I think it was the Bahamas.
How random.
Completely random, yeah. But anyways, he does a completely different field. So if you, so you search Greg Sawchyn on LinkedIn and you look for healthcare, you're going to find me. Honestly, like I don't do a lot of other social. Like I don't. I like to, as my kids say, I like to touch grass.
And Sawchyn, for folks listening and not watching, SAWCHYN, and we'll have the link to his LinkedIn profile in the show notes. But last question for you, Greg, as you look to the future of the industry, what are some of the changes that you're most excited about?
Yeah, I mean, healthcare is interesting. I mean, first of all, you have technology. I mean, I think we're really on the cusp with the combination of genetic knowledge, as well as just advancements in our understanding. And I hate to be sort of just like living the moment, but genuinely AI to really understand things that we don't understand today. Like, I really feel like sort of human health will be figured out probably in the next 10 years.
What do you mean human health will be figured out? That's
so,
a pretty big statement.
Yeah. So, I mean, the drivers of health, which doesn't necessarily lead to a therapeutic or a treatment or, I think, but just the drivers, like cancer is a great example where, we sort of bucket cancers into different categories based on where it starts and things like that. But, part of the challenge with cancer is that it's sort of like cell division gone haywire. There's different genetic mutations and things like that. It's really hard to get your head wrapped around. In fact, I don't think any human really can, from a sort of personal standpoint of knowing everything. But like you combine like genetic sequencing, you combine that with potentially AI, and like you're going to know exactly what's going on with that person, and hopefully how to treat them in a way that's just not possible today. I've been in sort of like the analytics space, and we've never talked about that, but like that, it's always been an interest of mine. One of my major switches was computer information systems back in the day. I'm actually only a couple classes away from a degree in that, but I've seen just even from like when the hype first started a couple of years ago with Chat GPT, just the advancement in 2 years has been unbelievable, to the extent where AI has effectively replaced Google for me at this point. It knows a lot, like things that you can ask it, it will give you accurate answers on very complex topics. I think that combined with just knowledge, and especially for complex patients, I think we're on the cusp of being able to put a 400-page, medical record into an AI, and it saying, hey, this is what this medications the patient should be on. This is what's going to happen next. This is, and it's all probabilistic. It's nothing's ever for sure, but anything a physician does is going to be probabilistic as well. I think we're really on a cusp of that happening in the next, call it 10 years of really being able to figure that out.
Is there something that this combination of AI, analytics, genomic sequencing can already do for us that might surprise a lot of listeners?
Yeah, I mean, I think that a lot of it's being used right now in pharmaceutical development. I think that's probably a space where it's furthest along. Some of it's being used in cancer diagnostics. Like a lot of times, if you're diagnosed with a new cancer, they'll send a blood sample or a tumor sample off to have genetic sequencing. Even cancer targeted therapies are all, some of them are very much based on mutations that you've had within your particular cancer, and it's very targeted in that way. So I think we're already doing some of it, but it's still being driven by, call it the limitations of a single brain. Mm-hmm. And so we're on the cusp of not being limited to a single brain or a single oncologist making a decision, of having a brain that is legitimately capable of taking in all medical knowledge known, putting pieces together that, just because a human brain cannot take in all the medical knowledge ever known, and synthesizing very quickly, what a logical next step might be. And that honestly, that's something I'm very excited about. From that standpoint in healthcare. Like I think in many industries, honestly, it's going to be tougher in healthcare than some other things. Like, next year, I bet 10 to 20% of Americans are doing their taxes completely by taking a picture and AI just fills it out. The fact that we're not doing it this year, like, I think TurboTax missed the ball, but maybe they'll get it together for next year, but we'll see.
All right. Well, for me anyways, you heard it here first, folks. People are going to be doing their taxes with photographs and AI next year. It's going to be very exciting to follow the future of AI in the healthcare space. Maybe we'll have you back to talk about it at some point. But for now, Dr. Greg Sawchyn, I want to thank you for sharing both your time and your story with us today. I really appreciate it.
Yeah, thanks, Anthony. Thanks for having me.
Folks, that's a wrap on another episode of the Inspired Stories podcast. Thanks for learning with us today.